welcome to IHW Council's special web series on women's health. I'm Anisha Nair-Dhawan, and you're watching our exclusive show on women's care during COVID-19. The ongoing pandemic has raised serious concerns among everyone, and women are certainly facing the brunt of it. The impact of this virus on their pregnancy, childbirth, family planning, or even the more regular and common needs such as menstrual hygiene, nutrition, or mental health are among the many issues that women are facing today. And there's one more thing that is causing immense suffering to many, and that is the inability to conceive. Infertility over the years has emerged as one of the most common problems being faced by young couples. Now, according to the Indian Society of Assisted Reproduction, infertility currently affects about 10 to 14% of the Indian population. And the scene is even worse in urban areas where 1 in every 6 couples is affected because of infertility. Our show today is special as we are going to discuss various aspects related to fertility in IVF treatment during COVID-19. And to guide you for that and answer all your queries on this, we have Dr. Kamini A Rao, Medical Director, Milann, the Fertility Centre. Welcome, Dr. Rao, to the show.
Thank you.
Now, before I begin our conversation, I would request our online viewers today to keep sending us your questions. You can type it in the comment box and we'll be very happy to take it up. And Dr. Rao is here to help answer all those questions over the next 30 minutes. And do like and comment with your feedback and share this page, this special show with your friends or family members who may benefit from it. So get the word going. So let's begin, Dr. Rao. Now, a lot of people believe that there is an entire process which is involved once you get into assisted reproduction or fertility treatments. How true is this? Do you need to prepare yourself? I mean, is it mental preparation? Is it physical preparation? Is there any preparation actually involved?
I think the inability to conceive itself is a shock to the couple because everyone thinks it's the absolutely easy thing to do and they keep it to the last because they would say that the career comes first and then, of course, building the house. And then, of course, they would say that we'd like to do, become something big in life. And then before they know what's happened, they would have reached the age of 35, 38. And then they say, okay, fine, now click of a button. And then, boom, we're pregnant. And then at the end of 9 months, we have a baby. And alas, that doesn't happen. So then they start worrying. And that itself is a shock. So I would say that the reproductive clock is different from the chronological clock, and that is what we need to understand. Unlike the man, the woman's biological clock is very limited. So if you look at the biological clock, the best time to conceive would be between 25 to 29. And if we pass that, the reproductive aging starts coming in an exponential way. Once you reach 30, then you look at 30 to 35, and then again, there's a big drop in terms of the number of eggs that you have. And so you've got to be very careful that if you're trying to conceive at the age of 35 to where you go to 38 and then 39 and then 40, of course it's going to be difficult at the age of 40 than if you were at 25. So certainly mental preparation is required. And if you've tried all the simpler treatments and if it didn't work, because the very fact assisted reproduction itself means that you're giving a part of your privacy across to the infertility specialist itself is a big thing. So therefore, a lot of mental preparation is required, counseling is required, and then you go for the fertility treatment.
Right. So, ma'am, our entire effort in this exercise is to make people aware on, why it is important for them to act on time and not leave things for the last moment and then find themselves in trouble. Now, you said ideally the fertile age is 20 to 30, 25, 35 is also good. Now, you said mental preparation is required. Do you need physical preparation as well? Because, when you're younger, you're healthier. I remember when I was into my first job, there were no regular meals. We were running, we were working a lot around the clock. We would get a pack of peanuts and we'd eat them and make a meal of it. We would lose weight at the drop of a hat. Now, the same thing doesn't apply in your 30s. You will gain weight very quickly. Your body itself changes. So, does your body also require some kind of, readiness to be able to have good outcomes when you go for assisted uh, reproduction techniques?
Yes, it does, because as the mind needs preparation, the body also needs preparation. So, as healthy as you are at the age of 20, I think the body needs to be prepared at the age of 30 because there are certain illnesses, like, for example, metabolic disorders like diabetes, hypertension, and obesity. And we're looking at the polycystic ovarian disease, that is also something that has really crept up with the modern era. So these are some of the things that we have to actually look at. The right weight, the right amount, the height, weight, BMI should be looked at properly. So we need to look at all the pre-morbid conditions, and quite a lot of the new age kind of the new millennials are looking at trying to do 10 things at a time. Like, for example, work at home and work at the office, and then come and do a third job in the middle of the night, and then it becomes that the diurnal rhythm that is there in the body is also changed. You're working towards the USA time, you're working towards the UK time. So the thing is, the menstrual cycle goes haywire, and you're also looking at reproductive aging also becomes a big issue. So you're looking at the physical strain on your body is also much more. So if you're looking at 20, perhaps you can take the strain much better, but by the time you reach 30, your body wear and tear also starts showing. And by the time you're 40, then they are actually so overt that you can actually make that out with your blood pressure going up, and then you'll also land up with taking sugar tablets and a whole lot of things. So I think physically preparing yourself is also as important as mentally preparing yourself.
So, ma'am, what kind of preparation can you do physically to give yourself the best shot when you take the ART treatments? Is it attaining an ideal BMI? How does one get there? Is it having a good diet, a regulated diet, keep your sugars in check, keep up the exercise? Physically, how does one prepare? Because sometimes, a mismatch in hormones will also impact the kind of outcome we'll have. And the hormones do get impacted because of insulin, because that also impacts some of the sex hormones.
Yes, because if you look at our hormones, the fertility hormones, the FSH, the LH, the estrogens, and the progesterones, they're very much related to the obesity as well. So if you're going to get your body in shape, it means that your body has to be, in terms of the fat content, has to be regulated. Now, we have heard of this syndrome called the polycystic ovarian syndrome, and you see, almost if you look at the school going age, almost 3 out of every 10 children have the polycystic ovarian syndrome. And it's not that the only obese children have it, it's also the thin PCOS that we've been seeing that have it. So, which means that in such situations, the first thing is to see that the weight control starts from there, from school going age. It's not that when you start trying for a pregnancy, you must start much, much earlier. Now, the height and weight, the BMI, if you can maintain it anywhere between 23 to about 25, most of the people I see is, in the range of about 27 to 33 or so. So that is too high. I think you'll have to maintain that. Now, how do you maintain that? There are different ways. Certainly, feasting and fasting is not the way. I think what one needs to do is a regulated diet, good balanced diet, good amount of proteins, fats, and carbohydrates. I think you need to get good amount of exercise. Proper water content has to be maintained. So when you're looking at it, and also a graded reduction in weight is required. There's no need to do a very fast kind of weight loss, because that also tends to sag your skin and you look very sick. That's not the way to do it also. And sudden weight loss or sudden weight gain also changes your menstrual cycle pattern. So we have to be careful as to how we do it. So it's best to get across to a dietitian and to get that weight change. The other thing is the worry. In fact, many a time we've found that, the depression that people have. Depression, of course, is a very pathological term, but feeling low, and also the anxiety levels, and also marital conflicts. All these things do add up to changing the menstrual cycle patterns and also the obesity. So one needs to have a counselor and a check to find out how the home environment is, and to see how you can actually strengthen the home environment and see how the woman is made to feel wanted in the house and rather than ostracized. Because I've seen many a family where the woman is actually made to feel incomplete just because she didn't have a baby.
Or
So
child.
that's important. So it's the mind and body that has to be actually sort of prepared when she goes for the pregnancy, and to make her feel that just because she didn't have a baby, that she's not complete. So encouragement is what I would want from the whole family as she comes to the pregnancy, because a healthy mind and a healthy body will be a healthy uterus, and that is what I would like to say. We had actually underplayed the stress part of it on infertility, but that is now coming to the forefront. We have to see that she de-stresses when she comes for infertility treatment.
Right. Ma'am, what is the role of sleep in one's health? Now, you said you are seeing PCOS in school going and college going girls, and this is even a thin PCOS. Why are we seeing PCOS amongst young people who may not be necessarily obese? And how important is sleep? Because that also sets your body's rhythm. If you expose yourself to the sun in the morning, the body gets the right cues that morning is the time to be awake, night is the time for rest, and rest is important because your body, your cells, they repair when you get rest.
Yes, it is extremely important. I think 8 hours of sleep is very, very important for the body. And if we rob the sleep and say that we'll only take 4 hours of sleep, and I think in these days when there is so much of portions to finish for the exams, you start sleeping only for say 3 hours or 4 hours. And then what happens is that the sleep deprivation also tends to cause a lot of insulin imbalance, and that causes a lot of weight increase. And this is something that also can result into a PCOS kind of a syndrome. So we must understand that when you see these kind of syndromes, also we find that the kind of food that the children eat today, the junk food that they're actually used to, the heat and eat kind of food, and not having the fresh food. Luckily, with the COVID that is around the corner, we are seeing more people having fresh food at home, and parents being at home. We find that 3 cooked meals a day, and we are seeing a lot of difference with fresh air, and also indoor exercises. So I think COVID is not all bad. It's also good because it's given a lot of discipline into children now, and we've seen that children are now following a very healthy, balanced diet. But that kind of junk food is also one of the reasons that this has happened, and it's also genetic, I must tell you, and it is multifactorial in its inheritance. If the mother has a PCOS, then there's a high chance that the daughter could also have PCOS.
All right. Ma'am, we've started receiving a few questions, and I'll take up the question which is coming from a Facebook user. What is the treatment of infertility in women with polycystic ovary syndrome? Is there one protocol that is followed? PCOS may be one of the only issues that is leading to infertility in a couple that presents yourself. How do you treat infertility in women who have PCOS?
I think that is the most difficult question. There is no one size fits all. I think when you have a person who has PCOS, you'll have to study the hormone levels. And once you look at the hormone levels, there are people who will look at the FSH, LH levels, and also look at the ultrasound, look at her past history, look at her menstrual cycles, look at also the obstetric history. Has she had, repeated miscarriages and things like this? So if a person who is fresh and she comes to you with long periods of infertility, is she hirsuted? Because with these polycystic ovarian syndrome patients, they are also hirsuted. They also have very oily skins. They are obese. So when you have a syndrome with all these features, you'll have to consider taking each one of them into consideration. One is the fat, the hair growth, as well as the oily skin, and then the menstrual cycles. And then treat each one of them and look at which is the preponderance one. Now, with the irregular menstrual cycle and the hormone imbalance, you will have to treat these people with simple hormones, like, for example, the ovulogens, like chlorine citrate, or you can be looking at letrozole as a treatment, as a first-line treatment in these cases. However, one has to go in very, very carefully with these people, because too little is very little and it doesn't stimulate the ovary. But when you give a little bit more, you may get it almost like popcorn, with all these follicles coming up, and they may land up with a hyperstimulation syndrome. So it is better for the specialist to manage the polycystic ovarian cases, rather than being managed at home, or a DIY kit kind of situation where, you just take self-medicate. I think that is it is better for a specialist to manage the polycystic ovarian syndrome cases.
So, Dr. Rao, the two medicines you named just now, these are medicines that are taken orally, are they injected? And these medicines generally trigger ovulation at the right time, right?
Yes, these are oral ovulogens, that is, they're taken in the first half of the cycle, from the second day to the sixth day. But at the same time, once you take that, then you don't take anything. But about approximately a week after stopping the tablets is the time you're likely to have the ovulation. This has to be monitored by the ultrasound to see how the follicles are growing. There is no point in trying to give the ovulogens and then not monitor these cases, because sometimes even with the oral ovulogens, you can hyperstimulate, and that is the most important thing. So one has to be monitored by the doctor to see that these people are safe, to see when the ovulation occurs, and to be able to tell them to have planned relations at that time.
So in no circumstances should people try and get these medicines from a pharmacist and start taking them on their own, right?
I think they shouldn't do this thing. They should first get evaluated by a specialist, and then they should be prescribed by a specialist rather than self-medicate.
And of course, monitored at the same time as well.
Yes.
All right, ma'am, we have another question coming in from a Facebook user. The question is, how do fibroids affect pregnancy?
Well, fibroids are actually muscle tissue that has not actually formed the way it should, like in layers. It just forms a knot and becomes a small tumor, and it is not like a regular tumor, because it's only the local tissue that is knotted up. So this is fibrous tissue which is knotted up, and that's why it's called a fibroid. And this is like a space-occupying lesion, and it is stuck inside the muscle wall of the uterus. This actually sits there and doesn't allow the uterus to contract in a proper manner. When this fibroid actually comes inside the uterine cavity, it can prevent the pregnancy from implanting well, and therefore the chances of abortions are high. Suppose it is in the wall of the uterus, they can grow to big proportions, and therefore the chances of mid-trimester, that is, abortions at a later stage in pregnancy, can also occur. There are also chances that when these abortions these fibroids are there, they can prevent pregnancy from occurring, because, and also during periods, they can have very heavy periods. And I have seen people who can reduce their hemoglobin from even 12 to 14 grams to even about 4 to 5 grams with one period. And they just passed out in clots, because the uterus cannot contract properly, and therefore these blood vessels remain open, and then they gush the blood out. Therefore, these fibroids can be quite symptomatic, with heavy bleeding, prevention of implantation, early abortions, premature labor, and of course, retained placenta. So after the baby comes out, the placenta gets retained, and they can have bleeding then. And of course, these fibroids can also act as a deterrent in terms of misdiagnosis as an abnormality in the formation of the uterus. So in all, they can be absolutely asymptomatic. That means a person may have a large fibroid and you will never know about that fibroid till you are actually doing a cesarean and you're taking the baby out and the fibroid you just see incidentally there, to you can have the fibroid and it can cause havoc towards the pregnancy. So either way, if the fibroid is causing symptoms, then it needs to be removed. If it's not causing symptoms, it can remain there.
Right. And fibroids can be safely removed during the pregnancy as well?
I think during the pregnancy, during the progress of pregnancy, one doesn't touch the fibroid. At the time of delivery, well, if it's a normal delivery, nobody touches the fibroid. Usually 6 weeks after the delivery, if the fibroid is causing any problems, then it can be removed because it's very vascular. The uterus is very vascular. One doesn't try to remove the fibroid during the delivery or during pregnancy. It is usually post-delivery.
All right. Ma'am, we've received another question, which says, how does age affect infertility in men and women?
Well, as I have said earlier in my talk, that a woman has a limited reproductive potential, and as you have your periods perhaps by about 10 or 12 when you're 10, 12 years, and you perhaps have your periods till approximately say 45 to 48. But the chances of conception will be best perhaps by about 20 to maybe about 40 years. So you have about 2 decades for reproductive potential, which means that you are born with a certain number of eggs in the ovary. And every month, it is not mathematics that you just lose 1 egg per menstrual cycle, because some menstrual cycles, you may not release an egg, and sometimes you may release 4 to 5 eggs. And you start stimulating maybe with say 10, and then you may have ovulation with only 1 egg, but the others become atretic. So, which means that about 400 to 500 eggs that are there in the ovary, you will perhaps finish it off in these 2 decades. So there's hardly any eggs left for you. If you do not have eggs after 40, there's hardly a chance that you're going to get pregnant after that. So you may have some withdrawal bleeds, but you may not have eggs to get you pregnant. So that is as far as the woman is concerned. However, with the man, he can go on producing sperms throughout his life. So if you say that a man can produce a baby at the age of 50 or at the age of 80, the answer is yes, he can, because the spermatogenesis occurs throughout his life. That's the difference between the man and the woman.
Right. Ma'am, another question that we have received is, for a condition of azoospermia, whether one should go for IUI or ICSI?
I think there are 2 different things. One is teratozoospermia means abnormal sperms. That means if you've got less than 4% of normal sperms, that means 4 normal sperms for every 100 sperms counted under the high power microscope, it means you have teratozoospermia. And in such situations, if you use IUI, which means you're just washing the sperms, and then you're trying to put these sperms into the uterine cavity, you will find that the number of abnormal sperms there may not really give you an ideal result. Now, IUI is basically a very simple procedure where you wash the sperms and put it into the uterine cavity. Whereas ICSI is an intracytoplasmic sperm injection. It is an IVF. Plus, in the lab, they take a single sperm seen under a high power microscope and directly inject the egg with a normal sperm, which is selected after looking at the high power microscope and injected into the egg. So there is a higher chance of getting a normal sperm injected into the egg, and the resulting embryo is likely to be normal based on the morphology of the sperm. So the chances of pregnancy with an ICSI is going to be higher than with an IUI.
All right. Ma'am, another Facebook user is asking how to conceive with low AMH. Ma'am, what is AMH? In high, low, how does it affect infertility?
Well, AMH is an anti-Mullerian hormone. This tells you what is the start position in your ovary. If normally a woman who is in the age group of about 20 to 30 would have an AMH of about 3 to 4. And if a person who's polycystic ovary will have an AMH of 6 or 7. So I would like to say that if you have an AMH which is about 8 or 10, that's also bad because it's a lot of eggs that is packed up in the ovary, and that may not be good news because it will not actually have space for it to grow big. However, if you have an AMH of 3 or 4, which is very ideal, that means there is a good amount of stock in the ovary, and we don't have to worry about it. Whereas if a person who's at the age of say 30 has an AMH which is say 0.8 or say 0.5, then yes, it's a low AMH, which means that we have to be careful. We don't have too much of time, and we have very little in the stock, and we have to hurry up and pick up these eggs. Otherwise, we may be left with nothing. And besides, the ones that are left over are not likely to be the best of eggs. So we also have to understand that the amount of eggs that we will get best of embryos is also going to be limited.
All right, so the AMH remains an important consideration, and ma'am has explained how that impacts the number of eggs available to be fertilized for pregnancy. Now we have another question coming in, ma'am. Can you throw some light on a condition called hydrosalpinx and its role in infertility in women?
Yes, hydrosalpinx, as its name itself is self-explanatory. Salpinx means tube, hydro means water. So when the tubes are filled with water, they are stretched beyond their elastic limit, and then they become out of shape. Normally on ultrasound, you don't see the tubes. When you start seeing the tubes, it means that the tubes are abnormal. When these tubes are stretched beyond that capacity, when the tubes are stretched beyond that capacity, you'll find that these tubes will not function well. Besides, you also have water in the tubes. And when you have water in the tubes, stagnant water anywhere breeds infection. So therefore, you will find that this stagnant water in the tube could also have some infection. And this tube is directly connected to the uterus. So you could have this dirty water getting into the uterus. So whenever you go through any kind of treatment with IVF with hydrosalpinx, there is a possibility that some amount of this dirty water can actually trickle inside the uterine cavity, and that can actually spoil any chances of implantation of the embryo. So therefore, it is advised that if you have the hydrosalpinx, it's better to flip those hydrosalpinges and then go for an IVF. That is the reason why hydrosalpinges are not a welcome sign when you're going and doing assisted reproduction.
Ma'am, is clipping the tubes the only course of treatment available? Because, once you clip the tubes, then IVF is the only way to conceive.
Well, in any way, the hydrosalpinx is of no use anyway. The other thing, of course, one can do is if you do a laparoscope and you see that the tubes can be salvaged, and then you see that the tubes can be repaired, then yes, go ahead and repair the tubes. But the point is when the tubes are stretched beyond that limit, and if that elasticity goes of that tube, the chance of the tube returning to normal may not be there. But if the tube can return to normal when you do a laparoscopy and you can repair those tubes, then or by all means you will repair the tubes. If that cannot be repaired, then this will be the second option. Because even clipping the tube will only be through the laparoscope.
All right. Ma'am, we've got another question coming in on the AMH issue that we were discussing just a few minutes back. How does high AMH cause infertility? You explained that the too many eggs are also not such a great sign. So how can, is there a way to resolve this AMH issue? If it's too less, I mean, we're born with that eggs. How can we change it? But if there are too many, can some treatment be given so that it gets regulated?
You see, when you have a very high AMH, it means that the follicles which contain eggs are very tightly packed together as in PCOS. So when we talked about PCOS, I did say that when you give ovulogens or if you give any kind of stimulation to the ovaries, either they don't respond, it's an all or none phenomenon, or they respond like popcorn and you can have a hyperstimulation syndrome. So in such situations, what happens is when you have a very high AMH, you need to give a higher dose of stimulation. And in that case, you can have ovaries that can become like melons, and that could be a big issue, and you need to sort of take, sometimes people have had about 40 or 50 eggs taken out at one time. And that could be a situation where post removal of eggs, they tend to have bloating of the abdomen,
Abdomen.
and they could have water inside the chest, and they could have a rough period for about a week. So therefore, we try to avoid that. The other thing with these high AMH is also, it doesn't mean that just because you have 40 eggs or 50 eggs, it doesn't mean all eggs are perfect. So, quantity at the cost of quality. So therefore, you may not get all of them, perfect. So you may get about, if there are 50 eggs, you may get about 20 that are good, and the others may be immature or post-mature. So therefore, rather than having that kind of mixed number of quality of eggs, it's better to get about 10 or 12 and decent quality eggs. And that is the reason why when you have very high AMH, you have to be very careful when you stimulate them. And that is the reason high AMH can be a little bit tricky when you stimulate.
Right. But of course, your physician and the doctor will guide you on the best protocol that you should adopt in case you have high AMH, right?
It has to be individualized,
Yes.
personalized medicine in these cases.
All right. Ma'am, another question that we've got is, what are the chances of getting pregnant with endometriosis?
I think, I can say right from the spectrum of very easy to get pregnant to very difficult and not possible at all, because, endometriosis is a condition which can be, graded from very mild to very severe. So endometriosis per condition, if it's very, very mild, that, we never know that it is there. And, we come to know of it sometimes, at a cesarean when the woman is delivering. Then we see endometriosis and say, oh, she had endometriosis, but then she's pregnant. So it's a question of, it's a very complex disease. We really don't know the origin of this disease. However, if the ovaries have been sort of affected, both the ovaries have been affected, repeated surgeries on the ovary, it can be a crippling disease. It can cause a lot of pain during periods. In fact, if it affects the uterus, it's called adenomyosis. And then so many times, young women who have still not had their family will have had their uterus removed because of the severe pain. And things like this have happened. People have gone for surrogacy because of adenomyosis. So, the spectrum is so huge. Unless you see a patient, and then you'll be able to talk about endometriosis, rather than, it will be a full subject of at least 1 hour if I have to tell you about endometriosis. But it's enough to say that endometriosis is a very crippling disease.
Right. Ma'am, very quickly, if you can tell us how is the stage of endometriosis diagnosed, even if somebody is not seeking infertility treatment? How do you figure out whether it's okay or it's really bad? How can you tell? Are there any tests?
The first thing is the symptoms. I mean, if the lady comes to you with severe pain during periods, that will be the first thing that she will talk about. Or very rarely people come and say that when they have sex, they have a lot of pain, that is dyspareunia. And they will also talk to you about, spotting in between and severe pain. Or they will say pain during periods, but it persists after periods as well for a long time. Then you will find that the ovaries are enlarged. There's a lot of blood collected in the ovaries, which is an endometriotic cyst in the ovaries. It could be a single cyst or it could be a bilateral cyst. And these cysts can be of large proportions. They will be attached to the ovary. And then, of course, you can also have, the adenomyosis, where the uterus itself is, enlarged because there are lakes, that is blood lakes inside the wall of the uterus, which can be very, very painful, because this blood lakes are because of the menstruation that takes place in the wall of the uterus, but doesn't have an exit. So every time it sort of fills inside the wall of the uterus, it's almost like labor pains, because it stretches the wall of the uterus, but it doesn't come out. Until that clot gets absorbed, it will still pain. So it takes various duration of time. Like, for example, 3 days, 4 days, and finally it becomes one continuous pain throughout the menstrual cycle without any kind of relief. So that is how I would put as far as endometriosis is concerned. So the first and foremost would be the patient complaining of these pains. So
Okay.
a lot of research has been gone on in this particular case, and we've been looking at, and there are quite a few people and say that if you take out the uterus, the endometriosis will go, but the answer is no. Unless you remove the ovaries, the endometriosis will not go. So the culprit is not the uterus, the culprit is the ovaries.
All right. Ma'am, we'll take one last question, and this question comes from a Facebook user who's asking, is IVF the only treatment for infertility?
I think they are very far from the truth. IVF is one of the treatments for infertility. I think only 1/10 of the infertile couples may need IVF. There are a lot of treatments other than IVF, and ask them not to despair unless you explore all the options. I don't think that infertility should mean synonymous with IVF.
Right. Dr. Rao, thank you so much for joining us today and answering all the questions that you've taken up. Just to reiterate that Dr. Rao is the Medical Director, Milann Fertility Centre, and she has joined us all the way from Bangalore today. Thank you so much, ma'am, for joining us on this special show today.
Thank you very much.
Now, to the audience, if you have more questions, you can keep sending them to us. You can type them in the comment box. You can even send them to us as a WhatsApp. And we will use your questions in our next show, and we'll get our experts to answer these questions. Don't forget to follow us and stay updated on all your health concerns and well-being issues that we address at the ISW Council page very often. This program was supported by Bharat Serums and Vaccines under its public awareness initiative. We'll be back with our special show on women's healthcare next week at the same time. Do follow us on Facebook to get all the updates on our upcoming shows, and keep sending us your questions, and we'll certainly include them in our next show. Till then, take care, stay at home, and stay safe.